So today we're going to talk about cardiology and cardiac hemodynamics. So this is, I think, useful for those who are taking master in medicine, and also for anyone who are interested in cardiology, just to understand a little bit basic in terms of cardiac. So let's see the basic of the heart. So I'm sure you are all now familiar with the heart anatomy. So I just wanted to tell you now, this is actually the way the heart is contracting. Okay. So if you think about it, okay, when you do an echocardiogram, so the picture on your right is echocardiogram. And when you look at ejection fraction, which is the value of contractility of the heart, the normal ejection fraction for male is 52 to 72%. Normal ejection fraction for female is 54 to 74%. But if you were to look at a single muscle or a single heart muscle, you can see that they're only contracting about 25%. So where does this 52 and 64% number come? It actually comes from the fact that the heart actually contracts in multiple ways. So as you see at the red arrow here, it actually contracts longitudinally. So that's one way the heart contracts. You see this arrow here, it also contracts radially. And you see this arrow here, it also contracts circumferentially. Okay? If you look at the cardiac apex, it actually rotates anti-clockwise. The base of the heart actually rotates clockwise. Now, so even though a single cardiac muscle only contracts about 20 to 25%, when you look at the overall of the heart, for male, it will go about 52 to 72%, and for female, it's going to be between 54 to 74%. The thing that I wanted to draw your attention, if you look at the picture of the heart here, you can see that the left ventricle is thicker than the right ventricle. Okay, so the left ventricle, this wall, the thickness, the size of the wall, normal is between 6 to 9 millimeter for female, and between 6 to 10 millimeter for male. Okay, anything above that we consider as normal wall thickness for the left ventricle. For the right ventricle, the normal wall thickness is less than 5 millimeter. So anything that is more than 5 millimeter for right ventricle, whether it is men or women, that is considered abnormal. Now, you should not mistaken the abnormal thickness of the wall and the term called left ventricle hypertrophy. Now, left ventricle hypertrophy does not refer to the thickness of the wall per se. Rather, it refers to how heavy is your heart. Okay, so when we take your left ventricle and you drain the blood, and then you measure or you weigh the left ventricle, so that is left ventricle hypertrophy. Okay, so let me repeat again. So the normal value for left ventricle thickness for female is 6 to 9 millimeter. Normal for male is about 6 to 10 millimeter. This is different from left ventricle hypertrophy. Okay, left ventricle hypertrophy is how heavy is the heart. So for male, it shouldn't exceed 115 grams per meter cube. 115 grams per meter squared, not meter cube. And for female, it shouldn't exceed 95 grams per meter squared. Okay, so that is left ventricular wall thickness compared to left ventricle hypertrophy. Now, this is the muscle arrangement of the heart. The only important thing that I wanted to point here is that the right heart actually contracts in only one way. It contracts, majority is only one way, which is a longitudinal contraction. As compared to the left ventricle, as I tell you, it can have radial component, it can have longitudinal component, it also can have circumferential component in its contraction. So I hope you don't draw on the screen, okay? Now, this is just interesting heart anatomy fact, okay? So the left ventricle to the LVOT is positioned in an acute angle as opposed to the smooth relation of the right ventricle to the RVOT. So meaning that in the left side of the heart, as the blood flow from the mitral valve to the left ventricle, and from the left ventricle to aortic valve, it actually have to turn 90 degrees to the other side. So because of this, the way your heart muscle thickness and the way your heart anatomy must be exactly right so that the flow of blood is perfect. Now, you know that there is 4 types of leaflet in the heart. So you have mitral valve and aortic valve on the left side. You have tricuspid valve and pulmonary valve on the right side. So when you look at the left side, okay, one of the valve that is important, which is mitral valve, valve between the left atrium and left ventricle. So this valve has very unique property. So it has 2 leaflets. It has anterior and posterior mitral valve leaflet. The thing that is important to remember is the posterior mitral valve leaflet is actually shorter than the anterior mitral valve leaflet. Okay, so for example, if you have a situation whereby your left ventricle is dilated, and this left ventricle actually pull the papillary muscle upwards and cause mitral regurgitation, the leaflet that is affected more is the posterior mitral valve leaflet because it is shorter. Because it is shorter, it is restricted, it is scattered, it is stented more easily compared to the anterior mitral valve leaflet. Okay? So that is a salient thing about mitral valve leaflet. And when you look at the mitral valve annulus, it's actually not flat. It's actually saddle shaped. So what do you mean by saddle shape? If you remember when you eat your potato chips, your Pringles, so that is the shape of the mitral valve annulus. Okay, so it is highest at the anterior posterior dimension, and it's lowest at the commissural to the commissure direction. And when your left ventricle dilates, so this saddle shape that is very good in terms of contracting and relaxing is actually disrupted, and the saddle shape mitral valve actually become more and more planar. So that's one of the problems when left ventricle dilates. Now, another thing that is a fact about the left ventricle, you know that they have papillary muscle. Remember that the left ventricle has 2 papillary muscles. One is called anterolateral papillary muscle, and one is called posteromedial papillary muscle. Okay. Now, this muscle actually supplies the chordae tendineae to both leaflets. So, just remember, the anterolateral papillary muscle supplies chordae tendineae to the lateral part of the mitral valve, both anterior and posterior. The posteromedial papillary muscle gives chordae tendineae to both parts of the leaflet, anterior and posterior, but at the medial side of the mitral valve. Now, one of the favorite exam questions is when you have acute myocardial infarction, then the question is, which one of the muscle that can easily rupture? Is it the anterolateral or posteromedial? The answer is posteromedial because posteromedial papillary muscles only have a single blood supply, whereas anterolateral papillary muscle, they got dual blood supply, so not easily ruptured. When you look at the wall of the left ventricular outflow tract, meaning that when the blood goes in and as it goes out, okay, this tract, the wall is formed by the interventricular septum and what we call a mitral aortic curtain, and I will show you a bit later. So just now we talked about mitral valve on the left side. So they have 2 leaflets. What about aortic valve? So aortic valve has 3 leaflets. Okay, the leaflet is called right coronary, left coronary, and also the non-coronary cuff. Okay. Now, as opposed to mitral valve, which has its real annulus, so you have a fibrous tissue around the annulus, the aortic valve does not have true annulus. So the annulus is actually formed by the membranous septum, the muscular septum, and also the mitral aortic curtain. So that is the difference between the aortic valve and the mitral valve. So we talked about the papillary muscle just now. And another thing that I wanted to tell you, so when you calculate ejection fraction, for example, when you do echocardiogram, now this is another favorite exam question. Now if you do M-mode, so those of you who are familiar with echocardiogram, if you do M-mode, okay, M-mode is no longer recommended to use to calculate ejection fraction. So your Tycos formula, your Quinones formula, that one is no longer recommended to use for ejection fraction. So you don't use that anymore. So you have to use your biplane Simpson. Okay, you have to use your biplane Simpson. Now the problem with getting an ejection fraction from 2D is you have to do a geometrical assumption. You have to assume that the left ventricle is in a certain geometrical shape. So for example, when you do 2D M-mode, you are assuming that the left ventricle is shaped like a prolate ellipsoid. So that's why you can have a formula. And when you do biplane Simpson, you actually cut the left ventricle into 17 slices, where you assume each slices as a spherical shape. Again, you have a geometrical assumption. So this is a drawback of doing something by 2D echocardiogram. It is not as accurate if you do it with 3D echocardiogram. However, because 2D is the one that is most easily accessible, so we do it with 2D now. Just remember that amode, tychos, and quinonate is no longer accepted to do ejection fraction. You have to do it by biplane 2D echocardiogram, or what you call a biplane 2D Simpson. Now these are what I talked about just now. So this is just an anatomical of the left ventricle. You're actually looking from it at the top. So you can see on the left side that is the mitral valve. This is the anterior mitral valve leaflet, and this is posterior mitral valve leaflet. Okay. Now the posterior mitral valve leaflet, they have an indentation. So there's one indentation and one indentation here that actually separate the posterior mitral valve leaflet into three scallops. So you have P1, P2, and P3 scallop of the mitral valve. The anterior mitral valve leaflet doesn't have indentation. However, because of ease in terms of nomenclature, so what we do is the P1 mitral valve leaflet, we say that the leaflet opposite it is A1. P2 leaflet, the opposite is A2. P3 leaflet, the opposite is A3. So that is your mitral valve leaflet. It has two leaflets. What is the name? A1, A2, and A3 scallop. P1, P2, and P3 scallop. That is a mitral valve leaflet. And normally the posterior leaflet is shorter than the anterior leaflet. That's the mitral valve. So you can see now that the aortic valve is actually anterior to both the mitral valve and the tricuspid valve. So they have three cusps. The cusp that always opposite the interatrial septum here, that is called the non-coronary cusp. And this is also happen in echocardiogram. So how do you determine which one of the aortic valve leaflet is the cusp? So you know that this here is the non-coronary cusp, this here is the right coronary cusp, and this here is the left coronary cusp. And you know that the right coronary cusp gives rise to right coronary artery, and the left coronary cusp gives rise to left coronary artery. So this is aortic valve here, that is wedge between the mitral valve and the tricuspid valve leaflet. So the mitral valve has two leaflets, the aortic valve has three leaflets. The most anterior valve in our heart is the pulmonary valve here. So the pulmonary valve is the most anterior. Now that is the reason that when you do echocardiogram, transthoracic echocardiogram, sometimes it is difficult to get a nice pulmonary valve image. Why? Because the pulmonary valve is actually just behind your sternum. So your sternal bones actually prevent the imaging of that pulmonary valve. Now pulmonary valve also has three cusps. So the one that is not facing the aortic valve is called the anterior cusp. Then you also have the left cusp and the right cusp of the pulmonary valve. Now that left us with the tricuspid valve, which is the valve between the right atrium and the right ventricle. Now tricuspid valve, like its name, have three leaflets. Okay, so we have this leaflet here that is called the septal leaflet. Here it is the anterior leaflet, and here is the posterior leaflet. Okay, and normally the septal leaflet is the largest one, and it's also immobile. One thing that I wanted to draw your attention in terms of difference between mitral valve and tricuspid valve, if you look at around of the mitral valve annulus here, you can see that it is consists of fibrous tissue. But if you look at the tricuspid valve, around the annulus, there is no fibrous tissue. It is just the atrial wall. So the consequence of this, the mitral valve is not easily dilated compared to tricuspid valve. So in your patient with chronic atrial fibrillation, so what happens when you have chronic atrial fibrillation is that your left atrium and your right atrium dilate, and this can cause regurgitation. And the one that can have regurgitation more easily is the tricuspid valve, because the annulus is not a fibrous tissue as compared to the mitral valve. Okay? If you're wondering what is this thing here, that is your left atrial appendage. So those of you who do masters, so this is where your non-valvular atrial fibrillation stroke form. So the stroke or the blood clot 90% of the time form in the left atrial appendage if you have non-valvular atrial fibrillation. That's why you need warfarin or new oral anticoagulation in this patient. Okay? And if you want to cardiovert this patient, for example, you need to do a transesophageal echocardiogram first to look at the left atrial appendage and to make sure that there is no clot. Okay? That is all the valves on fast view. So now the right side here is just wanted to show you the orientation of the papillary muscle on the left side. So this down here is the papillary muscle. This thin structure here is the chordae tendineae, and this is the mitral valve leaflet. And this from here the mitral valve leaflet, which is the anterior mitral valve leaflet, to the annulus of the aortic valve. This is what we call the mitral aortic pattern. Just wanted to show you again the anterolateral and posteromedial papillary muscle, and the fact that the anterolateral supply both anterior and posterior mitral valve leaflet at the lateral side, and the posteromedial papillary muscle supply both the anterior and posterior leaflet at the medial. Okay. I just wanted to tell you as well that the chordae tendineae is actually divided into three. Okay, there is primary chordae, there is secondary chordae, and there is tertiary chordae. So what is the difference between these chordae? So the primary chordae is when this chordae tendineae is actually attached to the tip of the mitral valve leaflet. That's what we call primary chordae. So if this chordae were to rupture, what you have is flail mitral valve leaflet, and you can have severe mitral regurgitation. The second one is secondary chordae, and the secondary chordae is the chordae that is attached, rather than the tips of the leaflet, it is attached to the body of the leaflet. And you also have the tertiary chordae. The tertiary chordae is the chordae tendineae that actually attach the base of the mitral valve leaflet. So again, this is the papillary muscle, and that is the chordae tendineae here. This is just the view, the anterior view of the cardiac anatomy. So, ladies and gentlemen, when you look at chest X-ray, the cardiac silhouette that you see on chest X-ray is actually not left ventricle. Okay, it's actually right ventricle. You can only see it enlarged when you have left ventricular hypertrophy or someone with heart failure, in which the left ventricle is big and now has replaced your cardiac silhouette. And the right ventricle is actually your anterior structure of the heart. Another thing that I wanted to tell you, just for the sake of examination, is what we call dextrocardia. The term dextrocardia. What does dextrocardia mean? Now, the term dextrocardia is actually very simple. It is where the cardiac apex is directed. Okay. Now, normal cardiac apex is directed leftward. One more time. Normal cardiac apex is directed leftward. So that is called dextrocardia, when the cardiac apex is directed backward. Sorry, that is what's called levocardia, when it is directed leftward. Okay, so I just repeat. Okay, now when your cardiac apex is directed leftward like this, it is called levocardia. That is normal. Okay, so levocardia is normal. Now, dextrocardia is when the cardiac apex is situated on the right side. So when it flips to the right side, that is dextrocardia, and that is abnormal. Remember, levocardia is the apex to the left, normal. Dextrocardia is the apex to the right, abnormal. What if the apex is in the middle? That is what we call mesocardia. So I hope you understand the term dextro on the right side, abnormal. Levo on the left side, normal. Meso on the middle side. This actually refers to where does your cardiac apex orientate. Okay. Now, this just wanted to show you the fact that the mitral valve leaflet, so this is the commissure or the annulus of the mitral valve. Remember, I told you that it shapes like a Pringle, so that's the Pringles there. Okay. The highest is the anterior to posterior, and the lowest is commissure to commissure. And as your left ventricle dilates, this Pringle shape becomes more and more planar. This in front here is the aortic valve, and the area here between this aortic valve and the mitral valve, this is called the aortic mitral curtain. Why is this important, ladies and gentlemen? You have to remember that this mitral aortic curtain is one of the favorite places where vegetation, infectious endocarditis likes to go. So that's why it's important, this mitral aortic curtain. And it also forms part of the wall of the left ventricular outflow tract. I just wanted to show you what is the shape of the aortic valve. So this is the aortic valve here. It has three cusps. Now, compared to the mitral valve, which is rather flat, you can see that the aortic valve will go from up and down here. Okay, up and down there, up and down here. So literally, this red thing here, this blue thing here, and this yellow thing here is actually the annulus of the aortic valve. So that is very cumbersome. If you wanted to do measurement, to measure this is very cumbersome. Therefore, to make life easier, what we do is we do a virtual annulus. And the base of this aortic valve from here to here, and that is what we call as left ventricular outflow tract diameter. And we actually use that to calculate stroke volume that come up across the left ventricular outflow tract. Okay, so this is the left coronary, non-coronary, and right coronary class. So how do I remember this? I know that the right coronary class is always the one that is adjacent to the membranous septum. Okay, so that is the right coronary class. You can see here, this is where your coronary ostia. So this is the ostium of the left coronary artery. So the left coronary artery will come up here. So this is the ostium of the right coronary artery. So if you were wondering how do we do coronary angiogram, so what you do is we put in the catheter. So we put in catheter from your brachial artery or the femoral artery. It go up into the descending aorta, or it go into your brachial artery. Then finally it go into your aorta and come down. So your catheter, the shape is, there is a tip. So the tip can engage on the left side. Then we pump diet or contrast, then we can see. And then we can also do on the right side. And we can also do our angioplasty balloon and stenting through this ostium here. Okay. Now, as I told you, for male, ejection fraction is between 52 to 72%. You have to remember that. For female, it is between 54 to 74%. Okay. Remember, the ejection fraction is calculated from Bifrin-Simpson in transthoracic echocardiogram. However, ejection fraction is not the gold standard. See, echo is not the gold standard. The most accurate one, the gold standard, is cardiac MRI. Okay, and cardiac MRI is the gold standard. 3D echocardiogram is also good. It is almost as good as cardiac MRI, but we do not have easy access to 3D echocardiogram. Okay. EF, when you use Bifrin-Simpson, the advantage is you can take into account the regional wall motion abnormality. Okay, why do I say that? So imagine if you have left ventricle, because you divide the left ventricle into 17 portions. So any regional wall motion abnormalities, when you slice that portion of the left ventricle, you take into account that regional wall motion abnormality. So that is one of the advantages of the Bifrin-Simpson. So sometimes, if you take an exam, they might say, okay, what is the advantage of Bifrin-Simpson? Okay, so maybe the option will be, so A, the Bifrin-Simpson does not have geometrical assumption. That is wrong. Bifrin-Simpson does have geometrical assumption. Or second, Bifrin-Simpson is the most accurate one. No, it is not correct. Cardiac MRI is the most accurate one, followed by 3D. 3, it takes into account regional wall motion abnormalities. Yes, so that is the correct answer. All right, so that is one question. And I tell you the difference between wall thickness, which is just you measure the wall. For example, you measure the wall with a ruler. So the size for female is between 6 to 9 millimeters. The size for male is between 6 to 10 millimeters. So anything that is above this is considered abnormal. Okay. Now hypertrophy is how heavy is your heart. So the upper limit for male is 115 grams per meter square. The upper limit for female is 95 grams per meter square. And above that, we say that the patient has left ventricle hypertrophy. Now, fractional shortening, the normal value is more than 25%. So you're wondering what is fractional shortening? It's just how much does the muscle thicken, okay? Not how much the heart contracts, how much the muscle thickens. So normal is more than 25%. What about fractional area change? The normal is 35%. So what is fractional area change? This is a 2D measurement. So for example, you have the left ventricular in diastole, you trace the area. You have the left ventricular in systole, you trace the area. Then left ventricular in diastole minus left ventricular area in systole over left ventricular area in diastole times 100. Normal is more than 35%. Okay, that is area. Ejection fraction is volume. Okay, so left ventricular and diastolic volume minus left ventricle and systolic volume over left ventricle and diastolic volume times 100. That is ejection fraction. Okay, so you have to understand what is the difference between fractional shortening, fractional area change, and ejection fraction, which is a volumetric calculation. Okay, now this dP dt, I don't think you need to know this. This is actually an echo term in which you see the rate of rise of pressure in the left ventricle if you have mitral regurgitation. So if you have mitral regurgitation, we should only measure the rate of rise of pressure in the left ventricle. If it's more than 1,200 millimeter mercury per second, that is considered normal. There's another thing that is called T index. Okay, so if you kind of person that take echo exam or you are a cardiologist, you need to know this kind of thing. And a lot of people don't know. And even cardiologists they don't know. Okay, so T index is actually index of myocardial performance. If you look at the first 4 parameters here, this is all parameters of systole, how good your heart is contracting. Now the T index, on the other hand, it is a global index of myocardial performance. What is it? Basically, in terms of calculation, it is the isovolumetric contraction plus the isovolumetric relaxation over ejection time. The lower the number, the better it is. Why? Because you want your heart to spend more time in ejection, because the time when it ejects is the time when it works, compared to when it is in isovolumetric contraction and isovolumetric relaxation time. So the normal value for T index, because it takes into account the isovolumetric relaxation time, meaning that it takes into account diastole. Okay, so if we say an exam, the question is, what is the advantage of T index? So the advantage is it also takes into account the heart diastolic performance. The lower it is, the better. Okay, compared to the others, this is the bigger, the better. This the lower it is, the better. T index, index of myocardial performance. Now, I hope so far you understand, okay, at least until here, the basic of the heart, a little bit on echocardiogram, okay. I hope at the moment it's still exciting to you, okay. So now, I just wanted to go back a little bit on left ventricular geometry, because a lot of you don't understand this and mistaken left ventricular geometry with left ventricular wall thickness, okay. Now, when we're talking about left ventricular geometry, we are asking 2 questions. How heavy is the heart? That is number 1. And number 2 is, compared to the left ventricular cavity, okay, compared to the left ventricular cavity, how thick is the wall? Okay. Now you ask me to question, okay, doctor, how do we measure left ventricular mass or left ventricular mass index? Okay. The way we measure, only in left ventricular mass, we use MOD or 2D linear measurement to measure left ventricular mass. Now you use the MOD and we use the cube formula, okay, assuming that the left ventricle is shaped like a prolate ellipsoid. What is prolate ellipsoid? It looks like a rugby or American football ball. Okay. So what happens is you use this cube formula. Okay. So for example, imagine that all of this is a cube. So look at my pointer here, and all of this is a cube. So we have the diameter of the outer wall. Let's say this is capital D. Okay, and we have the diameter of the small wall. This is maybe the small d. So we do the calculation. Diameter over 3 cubes. So diameter over 3 cubes times 5 of the outer wall minus diameter over 3 pi cube of the inner wall. Then you got the volume of the wall of the left ventricle. Now the volume of the wall of the left ventricle, you time with the specific gravity of the heart muscle, which is 1.05 grams per meter cube. Therefore, you can get your left ventricular mass. Okay. How do we do this? Don't worry, the echocardiogram will do it for you. Okay. I'll just tell you again so that you understand. Okay. So when you do an echocardiogram, you can do one thing that is called MOD. Now remember that you cannot use MOD for ejection fraction. However, unfortunately, we still have to use MOD when we want to calculate left ventricular mass. The way we do it is that we assume the left ventricle is in the shape of prolate ellipsoid. And because we assume that the left ventricle is in a particular shape, we actually can do a formula. And what is the formula? So the formula for a volume in patient where they have a prolate ellipsoid shape, that is D, which is diameter, over 3 times pi. So that is the volume. So if you have the volume of the outer wall of that prolate ellipsoid minus the volume of the inner wall of that prolate ellipsoid, you have the volume of the wall, right? So you have the volume. Now how we get the mass? So volume times the specific gravity of the heart muscle equal mass. That is a constant, which is 1.05 grams per meter cube. So you got a volume times 1.05 gram per meter cube, then you get a left ventricular mass. How you get a left ventricular mass index? That is left ventricular mass divided by body surface area. Therefore, anything that you get above 115 gram per meter squared for male is abnormal hypertrophy. Anything that is above 95 grams per meter squared for female is abnormal, so hypertrophy. That is the real definition of left ventricular hypertrophy, not the thickness of the wall. Okay, so now you have to, you understand already how you answer whether the left ventricle is hypertrophy or whether it's not hypertrophy. What about the ratio of the wall thickness to the cavity? So this is what we call relative wall thickness. How thick is the wall compared to the left ventricular cavity? Now the formula to calculate this is 2 times posterior wall thickness in diastole over left ventricular internal dimension in diastole. All right. Any number that is more than 0.42 is considered abnormal. Okay. So one we have LV mass index, and another one we have relative wall thickness. Okay. So once we get these two numbers, we can actually plot into this 4 room here. All right. So let's say we just take male. If the male left ventricular mass index is less than 150 grams per meter squared, and the relative wall thickness is less than 0.42, they have a normal geometry. If they say the left ventricular mass index is more than 115 grams per meter squared, and the relative wall thickness is less than 0.42, this is eccentric hypertrophy. The left ventricle is heavy, but the wall is thin compared to the cavity. Okay. If it's more than 115 and the relative wall thickness is more than 0.42, that is concentric hypertrophy. Not only the left ventricle is heavy, the wall is also thick compared to the left ventricular cavity. Okay, so I hope you understand now what I mean by left ventricular wall thickness. What do I mean by left ventricular hypertrophy? What do I mean by concentric hypertrophy? What is thick compared to the cavity? Eccentric hypertrophy, normal geometry, and concentric remodeling. Okay. Now, why does it important? It is important because your left ventricle geometry actually changes very early when you have disease. That's why when you have someone with hypertension and when you have someone with diabetic mellitus, you wanted to control this very, very aggressively and very, very early because the changes actually come very early. Okay. That is about the left ventricle. Now we go to the right ventricle now. What is the fact of right ventricle? I hope you remember what I told you. The upper limit of normal is 5 millimeters. Anything that is above 5 millimeters for right ventricle is abnormal. It has different pressure loop, pressure volume loop compared to left ventricle. So what is this? Now the reason is, okay, the right ventricle it only has to pump against the pressure inside the pulmonary artery, which is not so high. That's why even though your right ventricle is thin wall, it can still pump normally because it only needs to pump against pulmonary artery. Now your left ventricle, it is made in a way that it is thick and it can stand the high pressure inside the aorta. So that's why, even though hypertension is not good for you, if you look at your patient in the clinic, it can actually withstand high blood pressure for many, many, many years. Because your left ventricle is actually made for that, the fact that the wall is thick. Now the right ventricle, on the other hand, it cannot tolerate high pressure. That's why in your patient with pulmonary arterial hypertension, the prognosis is actually very bad. Because what happens as the pulmonary artery pressure go higher and higher, because the right ventricle cannot tolerate this. So the right ventricle becomes very easily weakened, okay, when compared to left ventricle. So the right ventricle does not tolerate pressure overload very well. However, surprisingly, the right ventricle is actually tolerate volume overload very well. Now, that's why, for example, when you find out someone has atrial septal defect, you remember that ASD causes right-sided volume overload. You can see that they can tolerate right-sided volume overload quite well, even into their adulthood. Okay, that's one example. The other example of right-sided volume overload is someone with corrected tetralogy of Fellow. So the 4 components of tetralogy of Fellow, if you remember, is overriding of the aorta, ventricular septal defect, right ventricular outflow tract obstruction and right ventricular hypertrophy. However, when the surgeon do a complete repair of tetralogy of Fallot, oftentimes they put a transannular patch across the pulmonary valve. So what happens, this kind of patient, even from their childhood, they have free flow pulmonary vegetation. Now, surprisingly, when they come to you in adulthood, they are still okay, even though they have free flow pulmonary vegetation. Why? The reason because right ventricles tolerate volume overload better than forejaw overload. And one final example that I wanted to give you is sometimes people have accidents when they are young, okay, motorbike accident. So what happens is they have a blunt force trauma on your chest. During the accident, they actually ruptured their tricuspid valve leaflet, and this is called flare leaflet of the tricuspid valve. Okay, this is during their childhood. But only in their adulthood, they go, they do echocardiogram, they have an incidental finding of flare tricuspid valve leaflet, but they are still okay, even though the right ventricle is big. Okay? So just wanted to tell you that the right ventricle tolerates volume overload very well. And I tell you only the right ventricle, the contraction is longitudinally. Now remember that right ventricle and left ventricle, they actually share the interventricular septum. Okay? So part of the thing that pull the right ventricle in is the contraction of the interventricular septum. So the contraction of right ventricle not only depending on its own muscle fiber, it also depends on the left ventricle contribution through the interventricular septum. The inlet and outlet is not in fibrous continuity, so the inlet, which is the annulus of the tricuspid valve, is not in fibrous continuity with the annulus of the pulmonary valve. When you look at the left side, the inlet of the left ventricle, the mitral annulus, is actually in continuity with the aortic valve. You can see that the trabecular is coarser, and you have moderator band from septomarginal to anterior pulmonary muscle. I just wanted to pause here to tell you that, okay, we talk about, say, right ventricle, left atrium, right atrium. Now, we might think, okay, logically that we tell they are left or right because of their spatial relationship in space. Okay, we call something left ventricle because they are on the left side. We call something right because they are on the right side. This is not true. Okay, we call something left or ventricle or right ventricle, left atrium or right atrium based on their morphological characteristics intrinsic to that chamber. Okay, so I'll give you an example. Okay, now the characteristic of left ventricle is left ventricle has a smooth septal surface. It has fine trabeculation. It has chordae tendinae that attach to pulmonary muscle. So this is left ventricle, regardless whether it is situated on the left or on the right side. Okay, so the right ventricle is defined anatomically by coarse trabecular, the presence of moderator band, coarse septal surface, septophilic chordae tendinae. Okay, so it doesn't matter where it is, as long as it has that characteristic, we call it right ventricle. Same go for left atrium. So the left atrium, we don't call it left atrium because it is situated on the left. We call it left atrium because it has a certain characteristic. What is the characteristic of left atrium? It has appendage that is finger-like. So the left atrial appendage is finger-like. The left atrial appendage, the pectineal muscle of the left atrium is only inside the left atrial appendage. The pulmonary vein only insert into left atrial appendage. So this is the characteristics of the left atrial appendage, left atrium. And lastly, what is the characteristic of the right atrium? The appendage is triangular and it's broad base. The pectineal muscle actually comes out for the appendage into the right atrial wall. The IVC insert into the right atrium. So that is how we define right atrium. Not where it is, but what the anatomical characteristic is. Okay, so just a little bit of segue for you. So this is an anatomical specimen of the right ventricle. So this is the surface of the right ventricle here. Now I told you already what is the characteristic of the right ventricle. The septal surface is coarse. So this is, you know, this is right ventricle, doesn't matter where it is. It has a coarse trabecular. Okay, it has this septum. Part of the chordae tendinae of the septal leaflet is actually attached straight into the interventricular septum, even without needing to go to pulmonary muscle. So this is the characteristic of the right ventricle. Okay. Now, since we are here, I just wanted to give you some tips in terms of to remember the type of ventricular septal defect, or sometimes in exam they will ask you what is the type of ventricular septal defect. It's very easy, only 4 types. So this is the right atrium, this is the right ventricle. So this is the flow from the right atrium to the right ventricle. If you have hole here, because it is in the inlet portion, that is called an inlet VSD. So that is one type, inlet VSD. Okay. Now, if you go further down, you go to this side, you look, that is very muscularized. Okay, so any hole here is called muscular VSD. So you have now here, one is inlet VSD. You have one here, which is muscular VSD. Now this is in. If this is in, this is out. So any hole here, it is called outlet VSD. So you have an inlet VSD, you have muscular VSD, you have an outlet VSD. Okay. There is one other type of VSD which is between the annulus of the pulmonary valve and the septal leaflet, somewhere here. That is called perimembranous VSD. Okay. So that's only 4 types for you to remember. And it's easy to remember. Okay. I just show you again. Going in, inlet VSD, muscular VSD, outlet VSD, perimembranous, inlet, muscular, outlet, perimembranous. Okay. What is the commonest VSD in the young? Muscular VSD. However, majority of muscular VSD close when they go into adulthood. Okay. What is the most common VSD in adults? That is perimembranous ventricular septal defect here. Alright. Now, this outlet VSD, a lot of people can confuse you. They have other names as well. So if you heard things such as supracrystal VSD, if you heard a name such as doubly committed VSD, that's all variant of outlet VSD. Okay, so you do not need to worry. So again, inlet VSD, muscular VSD, outlet VSD, and perimembranous VSD. This just wanted to show you the pulmonary cast. If you remember, I showed you the aortic cast. It is exactly the same. Your pulmonary cast and also the aortic cast. Okay, the way it's configured is the same. It go up and go down. It go up and also it go down. Now this is the anatomy of the right side of the heart. This is your tricuspid valve. Remember, this is your septal leaflet. That's your anterior leaflet, and that is your posterior leaflet. Remember, when the tricuspid annulus dilated, it dilates towards its anterior and posterior direction. Okay. This here, this color here, this is called triangle of Koch. All right. So what is the boundary of the triangle of Koch? We have this, the tendon of Todero here. This is the insertion of the septal leaflet here, and this is the corollary sinus here. So this is the triangle of Koch. So why is this important? This is important because at the apex of the triangle of Koch set your AV node. And this AV node is very important because when you do surgery or when you do an ablation for electrophysiological procedure, you do not want to touch your atrioventricular node. Otherwise, your patient has a risk of developing complete heart block. Okay, so remember, this is again your tricuspid leaflet. So this is just the side view of the right side of the heart. Now I just wanted to show you. So this is the atrial part of the right heart. This is the ventricle part. That is the septal leaflet. That is anterior leaflet. Now this is the membranous part. Now if you have a hole here, look at my arrow there. You have what we call perimembranous VSD. Okay, if you have a hole there, it is perimembranous VSD. But if you have a hole there, you got something that is special. I don't know whether you ever heard it. It is called Gerbody defect. Gerbody, G-E-R-B-O-D-E, Gerbody defect, in which the shunt is between the left ventricle to the right atrium. So a shunt that is between the left ventricle to the right atrium is called Gerbody defect. It can happen congenitally. It also can happen iatrogenically when your surgeon make a mistake during operation. Okay, that is the anatomy of the right heart. Okay, so that's perimembranous VSD there. Okay, so let's recap. So what have we learned so far? Now I have teach about you the anatomy of the left ventricle, the anatomy of the mitral valve, the anatomy of the aortic valve. I have teach you the right ventricle, the anatomy of the tricuspid valve, and the anatomy of the pulmonary valve. I have teach you about the normal value of ejection fraction, the normal value of wall thickness. I've also teach you about the concept of left ventricular hypertrophy, the concept of relative wall thickness. I've tell you the concept of dextrocardia, levocardia, and mesocardia. I've also tell you the special characteristics of each of the specific cardiac chamber. So I hope you understand. If there is any question, then feel free to put it in the chat group. Okay. So I just continue a little bit more. So just wanted to show you, this is the leaflet of the tricuspid valve. So that is the anterior leaflet, that is the posterior leaflet. We cannot see a septal leaflet here. Just wanted, do you remember? The left ventricle, you actually have two papillary muscles. You have anterolateral and posteromedial. Now in terms of right ventricle, normally you have three papillary muscles as well. You have anterior papillary muscle, this is usually the biggest one. So you look at the asterisk here, that is actually the anterior papillary muscle, which is the biggest papillary muscle. Okay, and the anterior papillary muscle, it actually supplies chordae tendineae to anterior and posterior tricuspid leaflet. So that is the anterior papillary muscle. The second papillary muscle is the posterior pulmonary muscle. This is the green asterisk here. So the posterior papillary muscle, sometimes not only one, it can be bifid, it can also be three. Now the posterior papillary muscle also gives chordae tendineae to the posterior leaflet and also the septal leaflet. Okay, so anterior part muscle gives anterior and posterior part muscle gives posterior and septal. Okay, however, the septal papillary muscle, okay, they are very selfish. They only give chordae tendineae to the septal leaflet. All right. So you can see the arrow here. So I just wanted to show you the blue arrow here. So this here is the septal papillary muscle here. Now this septal papillary muscle only gives chordae tendineae to septal leaflet. Doesn't give to anterior and doesn't give to posterior. And one of the characteristics of the right ventricle, I just wanted to show you here. Now you look at the septal chordae tendineae here. This is actually attached to the septal papillary muscle. But if you look at this other septal chordae tendineae here, it is actually attached straight to the ventricle myocardium. Straight. This doesn't happen in left ventricle. So this is one definition of right ventricle. They have a septophilic leaflet, just like what I showed you here. All right. So remember the difference between papillary muscle on the left side and also papillary muscle on the right side. So this is just the difference in pressure volume loop relationship between the left ventricle and the right ventricle. And this just wanted to show you the longitudinal contraction that I tell you just now, the radial contraction, and also the circumferential contraction that make the ejection fraction go from 35% in the cardiac muscle to 52% for male and 54% for female. Okay. So, ladies and gentlemen, I will stop here. So we have almost 1 hour of talk. Okay. So just put me in the chat group. When do you want me to do the second part of this talk? So the cardiac pressure, the other things we haven't talked about yet. So maybe we will do that in part 2 of the talk. So tell me whether it is useful in the chat, your chat group. And tell me whether you want the second part, and tell me when you want the second part. So I thank you very much for your attention. Thanks for joining me in the United States today. So it's 6:31 a.m. here in Rochester, Minnesota. So if you have any question, I'm very happy to answer this for you. Thank you very much.